Hi, I'm going to talk today about the role of echocardiographic in the assessment of aortic stenosis and regurgitation. I would like to thank Dr. Muralidhar and team for doing this, annual TE for many years and giving me an opportunity to share my experience. So at the end of the session, the audience are going to get some information about the aortic stenosis, the way to quantify the severity of the stenosis, some of the challenges and pitfalls associated with some measurements, and briefly about the aortic insufficiency, commonly called as aortic regurgitation. And also we'll talk about the various methods of utilization for grading the severity of aortic regurgitation. So we'll start with a couple of questions. The first one, there's always a potential for error when we are measuring the aortic valve area, especially using the continuity equation. So what do you think is the highest source of error among these four parameters? And then based on this image given, so what do you think the severity of the aortic insufficiency? So as our previous speaker talked about the overview of anatomy of the aortic valve, and so you should be familiar by this time, the commonly used views, which is like starting from the left top, the mid-esophageal aortic valve short axis, then you have a long axis, and then in the gastric, commonly we used either a transgastric long axis or the deep transgastric long axis. So we are going to use pretty much 3 out of these 4 views in most of for qualitative as well as the quantitative assessment of aortic valve disorders. So coming back to the etiology per se for the aortic stenosis, it's broadly based on the age of presentation of the individual. If somebody is younger than 70-year-old, the predominant reason for the aortic stenosis is most probably going to be like bicuspid, which is like variant of the typical tricuspid aortic valve. And also about close to 1/3 will be contributed from either rheumatic or degenerative. But if an individual is above 70-year-old, the most common reason is going to be degenerative. There's a significant calcification of all those curves. In terms of assessment, it's like any other valve. You start with basic 2D morphology, or if you have the ability to do the 3D, it's well and good. Just by visualizing the movements and, placing a color flow Doppler just to get a sense. And then we move on to various quantitative measures, starting from peak velocity to all the way to the peak and the mean gradient. And sometimes we do measurements of the aortic valve area either directly or through indirect method using the planimetry as well as the continuity equation. So let's start with the very first method. Whenever you get a sense of visualizing the aortic valve, in this particular image, we are getting both mid-esophageal AV short axis as well as the AV long axis, kind of a zoom, so that we will have a better sense of the morphology. So again, the way the presentation depends on the underlying pathophysiology. And if you look at the right side where it shows that, the various etiology contributing for the aortic stenosis, in the elder population, the most common one going to be the senile, then contributing to calcification of the cusp. And that leads on to narrowing of the valve. Whereas in the rheumatism, the most common reason going to be like a fusioning of the commissure, where we tend to minimize the movement of the aortic valve. And occasionally in the younger population, we tend to see the variant, which is the bicuspid valve. So in continuation of the morphological assessments, you can see the valve movements are pretty much limited here. Then putting the color flow Doppler across the valve, you can see turbulency more on the aortic side. You do see some kind of a trace to mild aortic insufficiency on the left side. So again, when you look at this more closely, these are all some of the different forms of the valves where it's very, very hard to delineate whether this individual has more than a cusp. So the unicuspid is very, very rare variant of contributing factor for the aortic stenosis. This is a classical tri-leaflet, significant calcifications, and pretty limited movement. So move on to some of the quantitative measures. The very first method come to your mind is obviously to determine the peak velocity, and at the same time we can be able to get the mean and the peak gradient. The most common view used is either a deep transgastric long axis or a transgastric long axis to get the perfect alignment across the aortic valve. And the Doppler which we are pretty much required is the continuous wave Doppler. As you can see, there is a two kind of envelopes. One is very dense, and this kind of a more of a faint one. This dense one is more contributing from the left ventricular outflow tract, whereas the other one is from the aortic valve itself. And you can see all the measurements which has been utilized for quantifying the aortic valve stenosis, like starting from the peak velocity to all the way to the mean and the peak gradient. And whenever you do this, you have to keep in mind there is always a potential error. It can be flow related, what kind of hemodynamic support an individual is receiving. In a hyperdynamic environment, especially the post-bypass period, we tend to have some degree of inotropes, we tend to overestimate. So you have to keep that in mind. And some pathological conditions like any sepsis or associated severe AI can lead to overestimation of the peak and the mean gradient in these situations. And we're going to have a topic later today. It's about the low flow and then the low gradient stenosis. So I'm not going to talk in detail about that scenario. So we move on to, once we get a sense of peak velocity, mean, and the peak gradient, we already have, what category the particular individual is going to be. It's always better to have more parameters to finally define the severity and for the better management for the particular individual, whether it's more of a medical management to follow up or you need like a surgical intervention. So one of the things which we use is the aortic valve area, which is typically used either by direct method or the indirect method, which is called the continuity equation, which is nothing but the area of one side with the velocity has to be balanced by the area of the other side with the velocity. In this particular scenario, the A1 is going to be your aortic valve area, which is the unknown. We are going to have a peak velocity, or we're going to have the VTI of this aortic valve. The A2 is your LVOT area, and then the V2 is either the peak velocity or the LVOT VTA. So one of the parameters which we can use. For that, we'll start with the AV long axis, get the measurement of the LVOT diameter, and that's going to give the LVOT area, followed by, you can do the VTI, either the deep transgastric or the transgastric. In this particular example is about 27, and you can get the VTI of the aortic valve, which is about 95. So by putting together using this formula where the continuity equation, you are getting about close to 0.7 centimeters square, which is in favor of severe aortic stenosis. So this is where you start with, in calculating the actual aortic valve area. So the other way is to do a direct measurements, which is on the right side. You can see the normal aortic valve wide open with a surface area of more than 2.5 centimeters square, whereas the left side one is more of the stenotic, which is less than 1 centimeter square. In this example, it's 0.8. So basically use the mediasophageal AV short axis, kind of a zoom view where you can delineate the edges of the cusp. And of course, there is always a controversial about, where you are tracing, whether right at the tip or just below the tips. Those going to alter your measurements. When you move on to the next way, which is like, as most of us start using the 3D, that's going to help you to determine the aortic valve area in a better way. Why the reason is because you can actually delineate where you want a cursor to keep it right at the tip of the cusp, which is much more closely correlate with your actual valve area, rather than keeping the cusp at the middle portion of the AV area. So this tend to overestimate the aortic valve. And the final thing which you would like to do in some situations where you think like arrhythmia is contributing significantly, then you are going to see a lot of variation in the Doppler profile. You may have a strong beat or a weak beat. In that situations, one of the parameters which you would like to use is called dimensionless index. It's basically the ratio of the LVOT to the aortic valve. Either it can be a VTI or it can be the peak velocity. So it's nothing but just the velocity ratio. So if you do this, then you get this dimensionless index. So typically anything less than 1/4%, like 0.25, it's more in favor of severe stenosis. So by putting together, having all these parameters, you should be able to delineate the severity of the aortic stenosis. So just to summarize, it's kind of a high yielding slide if you're preparing for the boards. So the peak velocity should be more than 4, peak gradient should be ideally more than 65, and mean of 40, all in favor of severe aortic stenosis. When it comes to valve area, the actual area is kind of 1 or less, is kind of more in favor of severe, and the dimensionless index should be less than 25%. So when it comes to the measurements, we tend to make some error. It's all operator dependent, how we experience. Even in experienced hands, sometimes because of the visualization, some of the views going to be challenged. There's always a potential error as we are dependent on many, many parameters, especially in a classical example of using the continuity equation. We tend to get sometimes the discordant gradient. It's nothing but one method you may have a severe stenosis, the other one you may more of a moderate stenosis. So ultimately you look at 4 or 5 parameters and you take the majority of that one for finally to make the conclusion. So the potential areas which we tend to make error is obviously starting from the LVOT area itself, as well as the LVOT VTA, because the cursor has to be right about a centimeter in front of the aortic valve. If it's too close, we tend to underestimate the severity, and if it's too far away, you tend to overestimate as you are capturing a lot of the LV component. So you have to keep this in mind whenever you are doing the VTI across the LVOT. So that's about the aortic stenosis. The next few minutes, we're going to talk about the aortic regurgitation, which is another common disorder involving the aortic valve. When it comes to an etiology, again, we have multiple ways of presentation based on the age of the individual. We see a broad spectrum starting from, infant to all the way to the elder population. So always look for what is the underlying cause. It can be, again, a senile degenerative infective source, or just the variant of bicuspid aortic valve. And occasionally we see rheumatism as a contributing factor. But ultimately, most commonly, we tend to see more in the adolescent or in the early adult phase is more of something that's just altering the aortic root. Classical example is either Marfan syndrome or Marfanoid. It's going to cause a hugely dilated aortic root apparatus that leads to significant amount of aortic insufficiency. In terms of classification, there have been various classifications described in the textbooks, but commonly used one is more like similar to your Carpenter for the mitral regurgitation. You have a type 1, 2, and 3. The easy way to remember type 1 is just a normal movement, or you may have some perforation. Because of the dilated root, the cusp is not going to be coapting. Whereas type 2 is more of excessive, pretty much due to the prolapse, and type 3 is more of restriction, can be like calcific rheumatism, all those things. So move on to assessment. Similar to what we are looking at the aortic valve, you start with the overall appearance of the aortic root complex. and see the diameter, and then you try to get the sense. And then also you put a color flow dot across the aortic valve and see the directional of the flow, how far it's going into the LV or just confined to the LVOT. We also have some other quantitative measures. Various methods again used. The one which is highlighted is not commonly used for this particular purpose. So most of the time we just stick on to the jet area, jet width. We'll see one by one. So again, start with the basic assessment. You can use with the color and without color. You can see this classical example of very trace AI, just confined to the valve. And then you may see something little bit more than trace AI that's more on the anterior leaflet, but just not going all the way to the mitral valve. Whereas if it's a moderate, it's going to cross the mitral valve probably halfway through to the LV. But if it's a severe, maybe hitting against the wall of the LV. That's kind of way to start with the color flow estimation. And if you move on to the width itself, this one way is like the depth alone. But in this case, classical example is like, how far is that it's going, right? So we talked about one is more like a mild, the other one is more like a severe, where it's almost going to the apex or touching the papillary wall. The measurements, we have various methods. So obviously you can start with the jet width, which is in relation to the area, the length of the LVOT. So if the ratio of the jet to the LVOT is about less than, a third, is more like going into more of a mild. If it's 1/3 to 2/3 is more of a moderate, and more than 2/3, it's a severe category. There is some slight textbook difference, but this is just the easy way to remember. But just by doing the two-dimensional estimation. You can also do the area of the jet to the area of the LV. That's the second way of quantifying it. And we can do something called a Vena contracta, which is the narrowest portion where the flow convergence happens, which is usually right at the cusp area. So if it's more than 0.6 for this AI, it's considered as a severe. So once you get the sense, sometimes there will be indeterminate zone. We can use some other parameters, just like a pressure of time. So the easy way to do is obviously you depend on the continuous wave Doppler, where you can see from the deep transgastric view more of a forward flow towards the probe, and you can get this, the pressure of time as well as the deceleration time. So in this case, pressure of time is less than 200, which is in favor of, again, the severe AI. The final thing, which is not commonly used, it's similar to your mitral regurgitation. You can do a regurgitant volume that gives a regurgitant fraction as well as the effective regurgitant orifice area. The regurgitant volume, in order to determine, you should keep in mind there will be a forward flow across the aortic valve, but since most of them are coming back to the LV, you'll be overestimating. So the only way to determine the actual forward flow is you have to subtract the forward flow coming from the competent valve. Typically, we take the pulmonic valve. We can do a mitral valve, but it's recommended to do the pulmonic valve. So you do the VTI across the pulmonic, which is basically RVOT. You get the area, then you get the stroke volume across the RVOT. The same thing we do across the LVOT. Then if you minus, that's where you're going to be your regurgitant volume. Once you have the regurgitant volume, you basically divide over the total flow going across the aortic valve. That's going to give a regurgitant fraction. So in a typical situation, if it's less than 30% considered as a mild, if anything more than 50% is considered as severe. And then finally, once you get the regurgitant volume, you kind of divide over the VTI across the LVOT. That gives that, basically the AR VTI, where it gives the regurgitant orifice area. So that's the way you should go. Start with the volume, get the fraction, and then finally you get the regurgitant orifice area. Anything more than 0.3 for the AI considered as a severe. And the last one, which is more like, looking at the pulse wave Doppler using the descending aorta. The commonly used view is the descending aortic long axis view, where you can put the pulse wave Doppler right at the aorta, can see the reversal of the flow. If it's consistently having the reversal throughout the diastolic, that's more in favor of severe. So just to conclude, these are the parameters you can put together. Of course, you may have some time, some of them fit to moderate, some into the severe. So ultimately, you choose the majority of that. So the easy way to remember, start with the jet width at the AR jet at the right at the LVOT in relation to the width of the LVOT. So that gives the rough sense of the grade. And then if you need to do, you can do a vena contractors. Remember, all these parameters will work favorable more of a central jet. If anytime if it's an eccentric jet, it's always going to be challenged to get the ideal quantitative measures. So by default, you always say it's a severe unless you disprove it with other methods. So back to the couple of questions. The highest source, of course, all going to favor except this functional status can potentially lead to error in your measurement. But the highest source is most of the time, which will be either LVOT diameter or VTI, but definitely the VTI is where we tend to make mistakes. So you have to be very, very cautious whenever you are doing the pulse wave Doppler. And then the severity, we all know because the pressure uptime is so low, so it's going to be very severe. Just to summarize, we talked about the brief description of the aortic stenosis, various methods, and some of the challenges with this. And then ultimately we talked about the AR. Thank you again for your patient listening.